All right, so this is a presentation that about the topic that we have been studying since 2017, and is about how to assess brain tumor in children. Now, the disclaimer is that it's possible that this year there will be new RAPNO paper. So RAPNO is this group of people that are studying the assessment of brain tumors specifically in children, and they are coming out probably with a new paper, but I don't know when, so I cannot speak about that at the moment. Now, I call this lecture the elephant in the room because, as you know, elephant in the room is a way to say that this is a problem no one wants to discuss. And what is the elephant in the room? Well, we know that we need to assess the tumor response in children with oncological problem, so neuro-oncological problem. So we need to know whether or not the therapy is working. And to do so, especially when it comes to trial for assessment of new drugs or therapies in general, we need to have objective, reproducible, and measurable way to assess that, both clinically and radiologically. And these are the problems. Now, the solution, which is really the elephant in the room, is that we use for this, in order to assess pediatric brain tumor, a combination between methods that are used and are also were originally invented for the assessment of brain tumor in adults, which are completely different. And also, we use a combination of this and clinical experience, multidisciplinary team discussion, which is variable, okay? So it's very difficult to standardize the assessment in brain tumor. Another big deal is that these tumors are different by the biological point of view in comparison to the adult. Actually, some mutation that involves tumor in adult in the molecular landscape of adult neuro-oncology is completely different from pediatrics. And among the pediatric group, there are several completely different tumors. So the problem is that there is currently no consensus on standard to define tumor response in children. But I will try to give you some tips and at least an approach of the pediatric neuro-oncological assessment. I will show you the role of the contrast enhancement, which is really important. I will show you something, but I will be very fast on that because the assessment of pseudo-progression, pseudo-response is similar in adult and pediatric population. I will show you some pearl and pitfall. I will show you how to assess different kind of tumors and also use of volumetric. I will touch base on advanced techniques. So let's start with the role of the contrast. This is the role of the contrast was thought to be critical in the assessment of pediatric brain tumor in adults from the 1990s with the McDonald criteria that are very good to assess a glioblastoma. Why? Because the glioblastoma shows a complete rim enhancement and increases over time quite fast. So it geometrically, it works, it behaves like a sphere that enlarge. So it's very easy to apply this method. So to have two measurement on the axial plane perpendicular to each other, to do the product and to calculate this product over time to see if this tumor is going up or going down. Very, very easy. Now, the problem with that is the non-enhancing tumor is not assessed, and we know that this is a problem also in adults, not only because some are not straightforward radiological GBM, but are intermediate grades, but also because we know from some histopathological and also radiological studies that the edema is actually part of the tumor. Of course, it's not applicable to low grade because they do not enhance or enhance minimally in adult. I will show you how in pediatric population is a bit different. And of course, does not consider pseudo progression and pseudo response. Now, in 2010, the Remo criteria came out and tried to implement the McDonald criteria. So they say that the measurable lesion needs to be more than 10 millimeters. And why is that? Because actually very small lesion, on very small lesion, there is an effect of the slice thickness. So this is 1 centimeter is enough to be sure that you are measuring more or less the same thing in all the scans. They use axial post-control with the same product of the perpendicular diameters plus an evaluation of non-enhancing flare and T2 lesion. So basically the T2 abnormalities were also considered in the equation. And also the clinical feature and the presence of steroids therapy was considered. So this was definitely an improvement. And we have these categories, these 4 categories: complete response, when everything disappears. But I would like you to notice that everything needs to disappear for at least 4 weeks. In terms of enhancing lesion, but stable or improved non-enhancing flare and T2 lesion. And then we have partial response when you have 50% decrease and no progression of non-measurable lesions, stable T2 flare and no new lesion, while progression is at least one of these 3. So at least 25% more in this perpendicular diameter in the measurable lesion, any new lesion, or significant increase, which is subjectively evaluated, of T2 and flare lesion. So we have these 3 categories. Everything else falls in the stable disease. And why you think that everything else falls in the stable disease? How they found this percentage? Actually, this is arbitrary, but it's just to be sure that the change we are measuring is real, because a change of 10% can be really due to technical reasons, and especially if the shape of the tumor is complex and we are measuring only on one slide, this 10% change can be not representative of a true progression or response. So this is just to keep to be sure that what you are measuring is really real. But of course, this is also an intrinsic limitation of this method. So the Remo criteria is still widely used in all the clinical trials, including pediatric neuro-oncology, but is suboptimal by definition. So we are measuring in the Remo criteria the contrast. But the problem related to the contrast is that in children, the enhancement is really erratic, especially in the low-grade glioma. We rarely have glioblastoma in children. If we have a teenager or children older than 10 years old, we can have this infiltrative glioma, grade 2/grade 3, that resemble the adult tumors, but otherwise the tumor in children are different. Either we have brainstem gliomas, low grade, or so-called the IPG, which is pontine diffuse midline glioma, or we have very aggressive embryonal tumor, medulloblastoma, ATRT, and ATMR. We can have low-grade glioma that are mostly optic pathway gliomas, and we have ependymomas. These are the big group that we see. Of course, there are a lot of other categories, but in terms of the assessment, these are the more important. Now, look at this. This is an optic pathway glioma. This is probably a child with NF1, but look at this contrast. Is not representative of all the T2 changes, which is not edema. This is clearly infiltrative mass. So the contrast, we cannot measure only the contrast, but we have some problems in measuring these faint and infiltrative T2 changes. So we have a problem. Now, most of pediatric tumor enhance inhomogeneously. Sometimes they do not enhance. Cystic necrotic component can be present, and I put this question mark because do we measure the cystic component or not? This is another problem not yet explored. Ideally, we should measure both, and we should tell the clinician, you know, it's increasing, but it's just the cystic component and the ventricles are going down, so maybe this is compensation of CSF, and so on and so on. It's very, very difficult. And also about tumoral enhancement, we know that tumoral enhancement can vary in the same patient without treatment. Sometimes we scan the same patient with two different techniques, like a spin echo and gradient, and you see this enhancement going up and down. Maybe technical, maybe related to change in vasculopathy, but vascularization of the tumor, but is actually not related to the progression per se. And the size of the tumor for the low-grade glioma, in particularly for the optic pathway glioma, changes sometimes in the size can be independent from tumor-free survival and also independent from treatment. So just to recap, we have a situation here where low-grade gliomas can change in size, but clinically the child is okay, can enhance, not enhance. The enhancement can change due to technical reason or maybe vascular reason that are independent from the progression of the tumor per se. So we don't know how to assess this. And I'm telling you, for optic pathway glioma, we rely on the visual examination. However, we still need contrast. I mean, this is questionable because there are a lot of studies that say that we don't need contrast, but I just want to show you, this is one of our case that has been published. You will find in these two papers on tumor assessment in pediatric radiology that I think is sent to you, but also in the book chapter that we published with Sotirios for the European Society of Neuroradiology textbook. Look at this case, T2, and T1, some spotty area of enhancement. This is low-grade glioma centered in hypothalamus and chiasm. But look, over time, there are new areas of florid enhancement that were not present before. Okay, fine. I told you before that the enhancement per se doesn't mean progression, but increase of size is still considered progression. Of course, we need clinical consideration, but look at that. The areas of enhancement actually correspond to some areas that are larger now. And before, you see here, you can see CSF. Now the CSF area is filled by tumor. That is exactly what has progressed and what shows enhancement. So in our experience, enhancement is still useful because increases your sensitivity in diagnosis of tumor progression, because new areas of tumor tend to enhance in a more florid way. Now, how we assess high-grade glioma in children? Pseudo response and pseudo progression, they are exactly the same in adults and in children. So pseudo response, you know that we use angiogenetic therapy and we have that the contrast goes away, but this is actually after bevacizumab. So after 1 month, after discontinuation, we have more edema, new spotty areas. So this is actually through, this was a pseudo response, and this is true progression of the tumor that is confirmed over time. So when we use angiogenetic therapy, we can have a reduction of the enhancement. In children, MEK inhibitor can do like that, for instance. So we have also some drugs that are used only in children and can give you reduction of the enhancement, so pseudo response. And this is the classic example for this amazing paper from AJNR, and you can see that despite the reduction of the massive reduction of enhancement in this tumor due to bevacizumab, the flare abnormalities increases, and this is why they basically came out with the Remo criteria. Okay, so basically you are looking for a discrepancy between the enhancing component and the flare. Pseudo-progression is the other way around. So it's new enhancement or increase in edema due to the therapy. And histologically is distinct from true tumor progression, as well as the more delayed changes of the true radiation necrosis. So after a few days, you have acute transient and reversible edema, especially in radiotherapy. And in the subacute phase, after 3 weeks to 3 months, you can have an increase of the enhancement, that is the pseudoprogression. And then you can have radiation necrosis from 3 months up to years. But again, this is exactly the same process that happened in adults you are familiar with, but I want to stress that 1/3 of children treated with radiotherapy for diffuse midline glioma in the pons, so what we used to call the IPG, can show the evidence of pseudoprogression. So how you distinguish between the two? Well, we use perfusion, and we know that a combination between perfusion, diffusion, some people also uses spectroscopy, can help us in distinguish between true progression that shows increased neoangiogenesis, so increase CBV, and treatment-related changes that should not have these changes. And this is just another example with the new enhancement not showing any perfusion, and you have that then this reduces over time, so the perfusion at 1 month was actually indicative of pseudoprogression. Take in mind that there are a lot of other techniques with slightly different approach, but overall, and I keep it really simple, but then if you want to go in details, you can speak with Sotirios or other experts like Steffi or Queen Square. But you know, basically ASL and DCE basically show different. We are measuring different things, but more or less all of them have similar value in distinguishing pseudoprogression from true progression. Another thing we use a lot in our neuro-oncology MDT is the PET, in particularly choline PET and other metabolites that are not amino acids, that are not glucose, because of course the FDG PET shows increase of metabolism in the all the brain, so it's a bit difficult to distinguish between true increase of metabolism and the normal high metabolism of the brain, parenchyma. But remember that, again, the multiparametric approach can be helpful. But again, these are infiltrative astrocytomas grade 2/grade 3 going toward GBM that are very similar with the adult counterparts, okay? One thing that is useful in this patient is actually if you use a multiparametric approach to pick up the area that is more in the hotspot for the biopsy. This is, look at this infiltrative tumor here without enhancement, but with large area of perfusion, also including the basal ganglia that normally show high perfusion, but also with a localized area of diffusion. And what we did, we matched the map of increased perfusion and increased diffusion, and we found the hotspot for the biopsy that was actually the most anaplastic area of the tumor and allowed our pathologists to better assess the real entity of the tumor. So just to summarize so far, we shall not use the contrast in assessing low-grade tumors. We shall use multiparametric approach for the infiltrative tumor that are not the typical low-grade optic pathway gliomas. And we also should be aware of pitfall related to ADC values, because when we see ADC values, we think that a ninth grade show restriction, okay, because of high cellularity. But actually, We have also restriction in low-grade glioma that are treated during therapy, and we have, because probably the cells are dying and there is a tumor that is shrinking, so here the tumor volume is reducing, but the ADC is becoming darker. So in this case, this is not a sign of tumor progression, because the optic pathway glioma will never progress. Or very rarely will become more aggressive. But I mean, it's really, if they become aggressive, they are probably not a standard optic pathway glioma. So be aware of this difference between the application of ADC in the adult tumors and the application of ADC in low-grade tumor in children, in particularly optic pathway gliomas. So ADC changes needs to be evaluated in the clinical context. So the first teaching point that I want you to bring home is that when it comes to optic pathway glioma, you cannot use the ADC, you cannot use contrast. You may want to use the sites, but these are very complex in shape, so you need to correlate clinically. Okay? Actually, being this pilocytic astro, also the perfusion is not very helpful. If you have an infiltrative low-grade glioma, you can use all the multiparametric approach you would use in adult. Now, let's speak about specific categories of tumors, in particularly the diffuse intrinsic pontine glioma, diffuse midline glioma of the pons. This is pre-radiotherapy, this is post-radiotherapy. There has been a reduction in the size of the tumor, so this is tumor response. Fine. But actually, first of all, look, also the ventricles and the space between the folia is increased. So there has been some atrophy. And look, here it's more clear, looking at the lateral ventricle, that there has been an enlargement of the lateral ventricle. So in these children, because we use a lot of steroids, the change in size that we see in T2, because diffuse midline glioma rarely enhance, is actually in part at least due to a general atrophy due to corticosteroid. Okay, so steroid adjuvant therapy will make you overestimate the response to therapy. So when they normalize, this is a study from St. Jude, they realized that actually the change in volumes without normalization were much more than with normalization. Okay? On top of that, as you can see in both the graph, actually, even if you do not normalize, the tumor size goes down and then go up. So what the group from St. Jude hypothesized is that radiotherapy actually can have an effect on the edema rather than on the tumor, because the tumor survival does not, so the overall survival does not change a lot. And this is very, very important, because of course we do radiotherapy also for the quality of life that is a bit better, but remember that what we see can just be an effect of radiotherapy on the amount of water going up and down. This is the first point. Second point that was published by Ulrike now almost 10 years ago, there are in the diffuse pontine glioma, you have some areas of heterogeneity. So areas of T2 hypointensity, this is contrast enhancement with subtraction, a bit of restriction, and sometimes hyperfusion. These areas may be the real, this is of course an hypothesis because we don't have demonstration of that, but these areas may be just the most active anaplastic areas of the DIPG, which is why these children are dying, because we are just acting on the amount of water within the tumor rather than killing the tumoral cells. But this is very, very complex. And if you have any question, I'm very happy to answer afterwards, because I know that this is a lot of information. The same thing, you see again, tumor at presentation, and then it goes down, the edema goes down. So if you measure this, it's actually much better. But then after a while, it goes up again. This is again a paper from Ulrike, and again the group of St. Jude, showing this curve of first decrease during radiotherapy and then increase again of the tumor edema and ultimately of the tumor size. But look at the spectroscopy. It's always very bad and it's stable over time. So the spectroscopy is just to be more representative of the metabolic profile. Again, measurement seems to give us a wrong idea on what is going on. So it seems to be like a bad surrogate of tumor response. So how we assess the diffuse midline glioma? If we have discrete enhancing lesions, sometimes are present, we can measure them, we can use Reno, but be aware, 1/3 of them, they have pseudo progression. So you need to correlate with the timing with radiotherapy and how is the patient clinical. Second, no enhancing component, we can measure T2. There are studies with linear measurements of Reno, or also people that spend a lot of time doing volumetry. But be aware that this may represent just edema, so the water within the tumor, and the reduction can just be a transient effect of radiotherapy. And then we can have focal area of high cellularity that are represented on images by this heterogeneity, and this may be the real tumor, but this is a hypothesis that is very difficult to prove. And MRS may represent the surrogate of the metabolic profile, but again, we don't have reference values, this is still experimental, we don't have prospective studies. At the end of the day, do we really need to assess diffuse midline glioma? We know that there is no cure for them. We know that all of them, they unfortunately go very bad. And then we also know that these children need to be assessed mainly clinically. And sometimes we have a lot of problem distinguishing pseudo progression from true progression, from pseudo response, and we do a lot of speculation and so on. So I think that now we just need to be aware that there is an internal heterogeneity, that the changes in volume can be transient, and just describe what we see and reason together with the clinician. Now, speaking of pathway, optic pathway gliomas, I touched briefly optic pathway gliomas when I show you the speedful related to ADC and the value of contrast that is really just about sensitivity in picking up faint areas of enlargement, small area of tumor enlargement. Now, I told you that pediatric optic pathway glioma do not enhance homogeneously, and enhancement is not indicative of progression response. So do not measure enhancement. Do not say this is progressive because there is more enhancement. First, they, differently from the GBM, they have a very slow growth rate, and we use as a therapy some cytostatic. So stable disease is actually a sign of response to therapy. So do not say that the tumor is not going down, not becoming smaller, so it's not a response to therapy. Just saying that this is stable in size, but keep in mind that this means response to therapy. Remember that there can be a clinical radiological discrepancy. So if the child clinically is fine, small changes in the size should not be overcalled. So in my opinion, we should not write, oh, this is equivalent of 5%, 10% of changes, because this can be misleading. And when you have association with NF1, you have everything more complicated. First, because the biology of the tumor in NF1 is different, and NF1 tumor can disappear or become very smaller without treatment. And then because you have a lot of UBOs or PHASI, NF1 related PHASI all around, so the measurement becomes even more complicated. This is a case report, I think, from Giulio Zuccoli, 3-year-old with NF1 and a tumor, follow-up 9 months, no therapy whatsoever, the tumor is gone, just to show you how the sites can be misleading. So remember, there is no MRI criterion predictive of tumor growth and prognosis, and there is no correlation between tumor enhancement, internal structure, and the tumor clinical course. So that's very important. So what we can do? Well, NF1 patients would normally do not routinely screen them unless there are visual symptoms or a known tumor. Newly diagnosed OPG, we do a follow-up every 3 months for the first year and then every 6 months. If we have new progressive clinical signs, we do a short-term follow-up. We do linear measurement on the T2 and flare. So there was an upgrade on the Remo criteria by Van den Bent in 2011. They say, you know what, because the contrast is erratic, try to measure the T2. But be aware that this measurement may not be representative of true progression or response. And they included also minor response criteria, when also less changes that are less important were considered in the picture. But really, the bottom line is that look at the T2 and don't trust too much the measurement without clinical changes. And just to show you what we did, first of all, there is the Dodge classification that identifies different prognosis depending on the area of involvement of the optic pathway. And then you can see that the volumetry here, this is not under review, sorry, it was published 2 years ago, I forgot to change this, but the volumetry is obviously better representative of the real tumor size rather than the Reno criteria. And we see that when we have a discrepancy between the radiological report and the trial that needs to measure this tumor only on one slide, the same slide every time. I'm sorry if it sounds a bit complicated, but really the topic is very complicated, and I just want you to understand what's going on in terms of being not dogmatic when saying, this is for sure increase of 15%, because this can create, because your word matters, and this can create problem. So we found a discrepancy between volumetric assessment and the linear assessment that will have changed the management of the tumor. What was published by Patrick Els is that probably the advanced techniques of DTI is more representative of the microstructural changes and correlates better with clinical assessment of the tumor. So DTI is an imaging biomarker sensitive to microstructural changes, and in the future may be used a bit better as a marker of tumor progression. So just to recap all this complicated journey, how we assess OPG. Clinical correlation is critical. So ask how is clinically. If we need to measure, we use the T2, not the post-contrast. And if we really need, we can attempt a volumetry, but this we found more useful on a case-to-case base. So we have a doubt, okay, let's try to do a volumetry. It's time consuming, but just to show you that the complexity of the shape in the space of these tumors make Reno even less useful. Variation in enhancement, I said several times that this is very important, do not correlate with treatment response or with clinical symptoms. And correlation between the size and symptom is controversial, especially if we report small changes in size. There is a room for advanced techniques, but mainly DTI, because pilocytic astrocytoma can have high perfusion, and this is physiological due to the vascularity of this tumor. So do not think that increased perfusion means more aggressive tumor. We don't do perfusion whatsoever in these children, while we should do in all the cases of infiltrative glioma, because in this case it's very helpful, as I showed you before, for pseudo progression and pseudo response. So the important concept is that a one size fits all is not a good approach for pediatric brain tumor. You really need to understand which entity you are dealing with and change your approach. Now, just a couple of things, and then I'm very happy to take questions if there is still someone connected. First of all, I didn't speak about aggressive tumor like embryological tumor. This is more about diagnosis, the problem with embryological tumor. I have a lecture about that, but it's in, a medulloblastoma, ATRT, they are resected, ependymoma even, they are resected, okay? And the problem becomes how to follow up. So how to pick up a tumor progression, or actually a tumor recurrence in these children. First of all, aggressive tumor in children, embryonal tumor, can or cannot enhance. Medulloblastoma normally, but not all of them enhance. ATMR, they do not enhance normally. ATRT, 50-50. So if you see, but all of them, they have high cellularity. So all of them restrict on diffusion. So use the diffusion restriction to confirm that these are metastases and these are not just flow artifact. Look at this case, medulloblastoma operated under follow-up. What is this? This is vascular or not? This is vascular or not? What are that? Artifact or metastasis? Diffusion confirmed that these are nodules that restricts, and this is actually a diffuse leptomeningeal metastatic disease. You need to change the treatment, because otherwise you have, after 1 month or so, something like that. So use diffusion for the follow-up of these children more than contrast, because diffusion is more sensitive than contrast, and not especially if you have a 3 Tesla, so you do a resolve. So the multi-shot with thin slices. And also, it's very important that the vascular contrast can fool you. So you need to, you have less technical challenges in evaluating the diffusion. And this is another case that I show every time. This was a child with a nodule on the head that was suspicious for leukemia, was reported negative by the fellow originally, but then we sit together, we look together, and first of all, we found this area here. Again, not sure it's real, it's not real. This is a spin echo, a lot of vascular abnormalities, but look, the contrast here in skull base is very, very prominent. And if we do diffusion, this is extensive nodular leukemic involvement of the soft tissue of the skull base and of the orbit, confirmed on ADC, that confirm also these two localizations that we were not sure about on contrast. And look at the orbit. This is the lateral rectus. Part of it is restricting. So this is a nodular metastatic leukemic deposit, and this is the normal looking muscles, but look at the nodularity here. So again, use diffusion also for head and neck aggressive tumor. Finally, the pitfall can be in interpreting the so-called equivocal findings on MRI of the spinal cord. You can see here this linear enhancement, this vascular tumor, there is a bit of clumping of the cauda equina. This is very common. They found in 48 out of 100, so 50% of this had linear enhancement, clumping of the nerve root, and or both, and these were never associated with true metastatic disease and reduction, i.e. reduction of the survival. So that's very, very important. And if you have any doubt, you can use, again, diffusion restriction, which is the diffusion of the spine, which is challenging sometimes. And also you can use a drive or cis, so a high resolution steady state heavily T2 weighted sequence to pick up small nodules along the cauda equina. So this is a pitfall, keep that in mind. And this paper, there are a couple of papers, there are another from by Bruno Soares, but this is also very, very interesting. So in conclusion, and I hope I was clear, because I know that this lecture can be a bit confusing, there is no consensus in evaluation of treatment response in pediatric neuro-oncology. Reno is still widely used in the clinical trials, but is suboptimal. Contrast variation may be misleading, but we still use contrast, especially for low-grade gliomas, to either figure out if the increase our sensitivity in case of small increase in size of the tumor, or in picking up the hotspot for the biopsy. Different tumor, different assessment. Clinical correlation advanced technique can be useful. Advanced technique can be useful in the future for optic pathway glioma or to better understand the biology of diffuse midline glioma. And we use them in children as in adults for infiltrative brain tumor to differentiate true progression from pseudo progression. So that's it. And please, if you have any questions, just let me know. Questions?